it's a very heterogeneous, very variable condition. There's not a clear picture of like the timeline. Some people will have this condition for, a decade. It kind of depends on if and when they seek medical care and the quality of the care and the interventions. And some people will just, naturally recover after a stressful event. This will kind of disrupt HPG function. And then 3-6 months later, they may be up and running again. They just sort of hit a speed bump and they move past it. So I guess before we jump into sort of all of their treatment recommendations, it would make a bit of sense to go back and talk about sort of, what is hypothalamic amenorrhea? What are those complications? Sort of a little bit of the physiology behind it. And then it might be easier for people to understand why these specific treatment recommendations are made. So it's a very heterogeneous, very variable condition. There's not a clear picture of like the timeline. Some people will have this condition for, a decade. It kind of depends on if and when they seek medical care and the quality of the care and the interventions. And some people will just, naturally recover after a stressful event. This will kind of disrupt HPG function. And then 3-6 months later, they may be up and running again. They just sort of hit a speed bump and they move past it. But basically, you have a lot of athletes that will develop something like this. There's something called the athlete's triad. There is some interplay with exercise in general. The beta endorphins can have a little bit of a suppressive effect on the pituitary. This is an area where we kind of see a similar phenomenon in men, not to get too far off of the subject at hand, but it's an observation that's there. There's exercise, especially overtraining, and the beta endorphins, its effect on the pituitary, and then undernourishment, and then stress. And whether that stressor is just exercise, whether it's a psychological stressor, it plays a role. And I guess you could argue that, is there any condition where raising stress would be helpful or improve that condition?
I guess it depends on what you'd mean by stress. So raising cortisol, certainly so. But raising levels of stress is an interesting thing to talk about. It's obviously a pillar of health as well. But you want to be able to make the effort feel good in whatever life stressors send your way, whether it is the stress of raising a young child or the stress of having a unknown job situation or the stress of needing to resistance train. So a poor response to stress would be to worry about it, and then your sleep will go off because of it, your diet will go off, so all the other lifestyle pillars will fall down. And in that case, there is certainly no condition where you want to be like overly stressed to a point where you cannot handle it.
Yeah, and I think it goes to like, perceived stress and negative stressors rather than a positive stressor, like, challenging yourself to reach a goal is, largely going to be a positive stressor in most cases.
Yep.
But I guess to back up, why would someone even think that they might have hypothalamic amenorrhea? So this is when a woman stops having her regular menstrual cycle.
Yep.
And it wouldn't be because you're on a like progestin-only birth control. If you're on that and you develop amenorrhea, that can happen to a lot of women. That's considered within the normal range.
It's sort of the opposite of the PCOS spectrum. PCOS is also a very heterogeneous condition that kind of changes. We've done podcasts on PCOS in the past, but it's somewhat the opposite in that you usually have metabolic dysfunction because of poor nutrient status. Instead of overnutrition, it's undernutrition. Instead of usually less exercise, it is too much exercise. Often your leptin levels are lower. Often you have lower LH, lower FSH, lower estradiol, and occasionally low androgen status as well. So in general, poor output from the ovaries rather than too much output from the ovaries.
Yeah, and this gets into kind of what your workup looks like. So, they make recommendations about getting a good history and physical exam and a laboratory workup, because you don't just want to assume that this person has a leptin deficiency when they actually have a prolactinoma that's blocking their menstruation, their hormone production.
Perhaps they had a surgery and they had to take out half of their ovaries or an ovary and a half. and that can also mimic hypothalamic amenorrhea. But just like you can have primary and secondary hypogonadism in men, which primary would be the gonadal dysfunction, secondary would be hypothalamic and pituitary function. HA is hypothalamic dysfunction, of course.
Yeah, so you could you look at your gonadotropins and you can look at, okay, is this more of a HA phenotype, or is this more like premature ovarian insufficiency? Yep. That's a pretty clear delineation.
Yep.
You also want to look at things like, thyroid. It wouldn't be uncommon for someone to have a pretty profound hypothyroid state, lose their menstrual cycle, and then you don't add leptin to that. You would look at, okay, let's, figure out what's going on with the thyroid. Do they have antibodies? Do they need thyroid hormone replacement? Fix that root cause, and then you're going to fix the menstrual cycle downstream of that. So you look at all these things in the blood work. Depending on the length of time, they also had a recommendation in there for getting a DEXA scan for bone density, which I thought was a very good recommendation, because the patients that I see in practice, and I'm sure this is the same in your cases, they may have had several years of missing menses, presumably being in a low estrogen state, and they have not had a DEXA scan. And that's something we have a very low threshold to go ahead and get and see, where is this person in relation to bone density? Because that can steer basically, trajectory going forward, and how much emphasis you want to put on bone building. Yeah,
especially if the patient had this condition develop at 16 and now they're 21. That is a very different situation, because bone density, even in the early 20s, can be affected. We know this from growth hormone studies and IGF-1 studies. A 20-year-old versus a 40-year-old, IGF-1 and GH exogenous replacement or endogenous stimulation is not going to greatly improve bone mass at an age of 40, but at the age of 20, it certainly could. And like the same is likely true of correcting the hypothalamic amenorrhea.
Yeah, definitely increasing the estrogen signal. Basically, everything that your body produces to try and hold on to bone, you want to line up all those variables when you can still affect that peak bone density, which is not at age 40, but at age 20, you still have a lot of bone that can be added at that point.